So much, Joe, and you're right. When we talked about this 6 or 8 weeks ago, coming up with this topic, I said, this is something that I run into not too frequently, but occasionally on bypass. Even you have a patient that's just metabolically alkalotic, and nobody seems to do anything about it. You also see them occasionally in the ICU, and occasionally, more than occasionally, on ECMO. And we had one recently where the patient was probably about 7.59, 7.6. And I asked the attending physicians, and they were doing rounds, does anybody have any idea why this patient is alkalotic? No. Are we gonna do anything about? Are we gonna treat it? No, we're not gonna do anything about it. So I found that to be something fairly common in my career, is that we just seem to have these occasional patients that are metabolic alkalosis, and nothing seems to come of it. We just seem to sort of ride with it until what? And as perfusionists, we're probably detached from this. So this is really not about perfusion. This is about this topic, which I hope to learn a lot about in doing this. I'm not so sure I'm an expert on it.
Isn't that what they say, that the person that learns the most from a lecture is the person that's giving the lecture? Is that what they say?
Mm-hmm. I feel that way.
Mm-hmm. One time I was told an expert is someone from out of town with slides.
I like that.
That's even better. I like that.
I like that.
So here we go with this. So metabolic alkalosis is defined as a disease state where the pH is elevated above 7.45, secondary to some metabolic process that's causing that. This disease process results in a primary increase of the sodium bicarbonate concentration, either due to a loss of the hydrogen ions in your system or a gain in the bicarbonate ions. Why is this important? The biological effects of metabolic alkalosis are a direct result of hypovolemia, hypokalemia, and hypochloremia. So kind of keep those three things in mind. And they usually all tie in together. And that's a decrease in your circulating volume, decrease in potassium and chloride depletion. Well, this is important because it can lead to changes in arrhythmia changes, confusion, decreased myocardial contractility, which is going to translate to decreased blood flow, cerebral blood flow, increased neuromuscular excitability, and all these things are linked to this dysregulation of the potassium and chloride and or the volume. But here's the important thing I discovered, Joe. We talk about acidosis a lot, but in alkalosis, it shifts the oxygen dissociation curve to the left. It impairs peripheral oxygen unloading.
Wait. I'm sorry to interrupt you. Did you say if for alkalosis it shifts it to the left? I thought it shifted it to the right. If it shifts
right?
left,
Yes, it shifts to the right.
you release it more readily.
Okay,
If
so
it
it's to the
shifts
right?
To the
It's to
right,
the right.
to
It's
the
the
right.
opposite.
So
So sorry, it's probably just a typo on
Yeah,
your
it's a
slide, but I
typo
wanted
because-
to correct that before we got too much further.
okay, so I apologize for that. So
Okay,
it
shifts it to the
impairs
right.
your peripheral oxygen loading. So it shifts the oxidation curve to the right then, I'm sorry. So what happens is when you have this alkalosis, in addition to shifting the curve to the right, there's a compensatory increase in your arterial PCO2 through hypoventilation. Well, hypoventilation is also going to decrease your oxygenation. So you have a double impact there, which basically leads you to an overall net effect of systemic hypoxia. And this is not something I think most of us have thought much about, is that metabolic alkalosis is really leading us to a systemic hypoxic state. So when is metabolic alkalosis life-threatening? Well, the mortality associated with severe metabolic alkalosis is actually quite substantial. An arterial pH of 7.55 has a mortality rate of 45%, but arterial blood pH greater than 7.65 has a mortality rate of 80%. So this is why we care about this.
Wait. I don't want to interrupt you. Independently or
When you look at
associated with, like, you're saying just a metabolic acidosis uncompensated with a normal CO2, or are you saying there's other confounding factors?
Yeah, I mean,
why would it have a mortality rate of 80%? That's just trying to understand.
It's going to be the affiliated metabolic dysfunction that we're going to talk about. Because
Okay.
there's so much going on. In order for you to have a pH like that, now remember, pH is a logarithmic scale, right? So a small increase in pH is an exponential increase in actual. So what happens here is that there's a setup or a phase one or a cause or etiology of how you became alkalotic in the first place. So in order for the metabolic alkalosis to become established, there's basically 5 known etiologies, or what some people call precipitating factors. This precipitating factor is just a term that I read about that particular people use. It's not scientific, but it's one of the etiologies that sets up, and what they are is gastrointestinal hydrogen ion loss. In other words, vomiting or diarrhea. You can have a renal hydrogen ion loss, usually through diuretics or our aldosterone levels being high. You can have an intracellular shift of hydrogen ions on the intracellular level exchanging with low potassium, hypokalemia. You can also just have an administration of bicarbonate ions, like people who take a lot of antacids, or we can self-administrate to the patient too much bicarbonate in the hospital. But most commonly, it's what's called a contraction alkalosis, which is really a fancy word for patients who become dehydrated. Mm-hmm. So one of these 5 etiologies almost always is one or more of what sets the person up and becomes alkalotic in the first place. But what maintains the alkalosis is what's important, because those first phase 1 can be easily corrected lots of times. But what maintains the alkalosis on patients when you see they stay in metabolic alkalosis for days at a time is that there must be one of these maintenance factors in place also. And these are hypovolemia, reduced intravascular blood volume, decreased potassium, hypokalemia, hypochloremia, decreased chloride, or renal function, renal dysfunction, which in this particular dysfunction is going to reduce the ability of the bicarbonate ion to be removed. Or hyperaldosteronism. Anything that increases your aldosterone levels is going to have a double negative effect, which decreases your potassium and your hydrogen. We're going to talk about all of these here in a bit. So the premise for metabolic alkalosis is, in order for it to be created, there must be one or more of these etiologies, or what I call precipitating factors, in place. In order for the metabolic alkalosis to be maintained, there must be one or more of the maintenance factors in place. The reason for this is that the etiologies are the ones that increase the serum bicarbonate concentration in the first place, and the maintenance factors maintain the alkalosis. And how do they do that? They maintain the level of bicarbonate ions, the circulating bicarbonate ions, either by decreasing bicarbonate excretion or through increased bicarbonate reabsorption, which is sort of the same thing. Either way, your kidneys are not excreting the bicarbonate ion properly. So back to the causes or the etiologies, phase 1 of this. Those 5 things at the bottom there are actually easily rectified as long as renal function is maintained. Excess bicarbonate is excreted in the urine fairly rapidly. Like a lot of us have had vomiting or been dehydrated, and we don't go into metabolic alkalosis. Our renal function is normal, and we excrete the excess bicarbonate ion fairly rapidly. Well, in people that maintain their alkalosis, the metabolic alkalosis will persevere because these maintenance factors that are also in place reduce the kidney's ability to eliminate these excess bicarbonate ions. So that's how you stay in metabolic alkalosis. So looking at these 5 causes and the etiologies again, we're going to look at each one and what they do and how they cause the alkalosis. So first of all, the gastrointestinal or GI hydrogen ion loss. Well, you have upper GI, you can have an upper GI factor, which is either vomiting, or we can also see this in the hospital, we have excessive GI tube suctioning. Or you can have a lower GI, which is usually diarrhea, or people who use excessive laxatives or enemas. So let's look at the upper GI one. So one of the important things to know, a lot of us probably have forgotten, is that the pH of your stomach fluids are 1.5 to 3.5. And what I was saying earlier, because it's a logarithmic scale, imagine how incredibly acidotic that is and how much hydrogen ions are actually present to produce that type of pH. So hydrogen secretion enters the stomach through the cells in the lining of the gastric mucosa, but when you lose these gastric secretions, you lose a lot of hydrogen ions. Well, in order to maintain the normal gastric pH, the hydrogen ions will make their way from the blood, will be replenished back into the into the gastric mucosa, leading to an increase in the concentration bicarbonate in the blood, right? Because you're losing hydrogen ion. Thus is driving your alkalosis, okay? In the lower GI situation, diarrhea, excessive laxatives. So chronic use of excessive of laxatives or enemas or any form of diarrhea really are most commonly the cause of low potassium levels. So on the upper GI was a loss of hydrogen ions, but in the lower GI it's largely a loss of potassium. And we're going to see how that affects it. So the laxatives and enemas at high doses can cause a loss of potassium in the stool, especially if they result in diarrhea. So excessive diarrhea will trigger alkalosis because the low potassium causes a decrease in hydrogen ion concentration. So I want you to hold that thought because I'm going to show you why and how low potassium causes decreased hydrogen ion. So you can have a GI hydrogen loss, you can have a renal hydrogen ion loss. So now, what's an important key to remember? That hydrogen is used within the kidneys as an exchange ion to maintain the electrical balance of other ions. That's what you have to important to remember. The reason hydrogen comes into play when all these other ions become depleted is that hydrogen is used as the exchange ion. Number two key to remember is aldosterone, which is an antidiuretic, causes retention of sodium in water, therefore it's an antidiuretic, to be reabsorbed in exchange for hydrogen and potassium. So therefore, conditions or pathologies that increase the level of aldosterone or the effect of aldosterone lead to hypernatremia, low potassium, hypokalemia, and decreased hydrogen levels. So just to give you some example, Conn syndrome is one such pathology, which is hyperaldosteronism. And just having low blood pressure, low blood volume, low blood pressure, will also increase your aldosterone production because your kidneys are going to try to increase your blood pressure. We're going to talk more about those. Now, diuretics cause increased excretion of potassium through the urine. Loop and thiazide diuretics are capable of inducing aldosteronism production just by the fact of what they're doing. They're decreasing the volume and therefore can decrease your blood pressure, but then the kidneys respond to that and stimulate the renin, angiotensin, aldosterone system, which then produces aldosterone. So, you know, what's interesting, even though you give somebody diuretics, which you want to lower their blood pressure oftentimes while you're doing that, your body counteracts that by producing aldosterone, and this can also tend to bring you towards maintaining metabolic alkalosis. So now there's two genetic defects that are out there. They're pretty rare, but you see them whenever you read something about metabolic alkalosis. This came up in every article I read. Bartter and Gittleman disease are genetic defects. They're rare, but they're genetic defects that lead to decreased expression of these ion transporters in the loop of Henle. But these syndromes have the net effect of the loop and thiazide diuretics respectively. In fact, Bartter syndrome almost mimics what a loop diuretic would do, and Gittleman disease mimics what thiazide diuretic would do. It's just interesting. So now let's look at intracellular shift of hydrogen ions, hypokalemia. The key to remember is anytime hydrogen ions are shifted intracellularly, it creates a relative increase in the bicarbonate ion concentration, right? Which increases your pH. So basically, your bicarbonate ion is increasing, not net, but as a result of a lack of hydrogen being present. So here's what I said about hold that thought earlier. Shift of hydrogen ions into the intracellular space is caused by a low potassium, hypokalemia. Due to a low extracellular potassium concentration, potassium shifts out of the cells, so the body is going to try to correct this low potassium, and it's an intracellular ion, right? Potassium's intracellular, there's tons of it intracellularly. It's just going to shift some extracellularly to try to bring your potassium back up, but in doing that, it has to exchange for something. There's a price to be paid. It has to exchange with hydrogen. So in order to maintain the electrical neutrality, hydrogen ion shifts into the cells, raising the pH, maintaining alkalosis. So what you see here is, just for an example, if there's your cell and you have low potassium, and let's just say 4 potassium cells exit the cell, you have to have 4 hydrogen ions enter the cell. And this, in order to maintain the electrical neutrality of the cell, well, this is what's driving your alkalosis. Now you can have number 5, which is, or number 4, administration and retention of bicarbonate ions, right? So we can just have etiologies that lead to increased bicarbonate? Well, the most common one, Joe, you mentioned this when we were talking about this, is that we see patients that are COPD, right, and they've naturally compensated. So what you have is in COPD patients, a patient hypoventilates, retaining their CO2, and this subsequently produces the acidosis. So over time, the renal system compensates by retaining bicarbonate to balance the pH. But if we take this patient into the hospital and we correct the hypoventilation, such as when they're on a ventilator, the CO2 levels will decrease, but the bicarbonate levels still remain, and they're very slow to reduce. And this is why it's very challenging. I'm sure Dr. Samir can talk a lot about this, is when you have a COPD patient on the ventilator, you try to get them off very quickly, correct?
Absolutely.
Because of this problem. So this is going to cause post-hypercapnia metabolic alkalosis, which is slowly self-correcting. Or you can have just a consumption of oral antacids. Sometimes people take a lot of antacids, but commonly you see it with people taking calcium bicarbonate with osteoporosis conditions. You can also have, believe it or not, an alkalosis due to overconsumption of milk or an overconsumption of black licorice. You have to consume.
I love that. I love black licorice.
If you consume a lot of it over a 3-day period, you could have this condition. In fact, the FDA, if you Google this, the FDA had released a statement about the warnings of overconsumption of black licorice.
Yes.
So-
You can get, in fact, you can get severe hyperkalemia. Actually, there have been
That's what
patients,
happens.
people who have arrested,
Right.
yeah, from it.
Yeah. So
They
right.
have.
We'll put you on ECMO, don't worry.
Well, okay. All right. Well, since you broke the ice, I have to make a very quick announcement. It was a test, and I want you to all know that you've all done poorly on this test.
Oh.
Alkalosis shifts the oxyhemoglobin curve to the left.
I was right.
You were correct. You should have stood by it. And all of y'all, when I said it, were like, oh, yeah.
Okay.
See, I led you right down the path. But JCAM pointed it out to me. Vicky has pointed it out to me. Everyone has pointed out that it was a test, though. See, I was only exploring your veracity.
Now you're exploring that we're following the leader.
Don't follow me to the abyss. John, go ahead. I'm sorry.
Well, I think I deserve a free cup then.
You do. You get John gets a free Perf Web cup. So does JCAM.
You know that
So does
saying.
JCAM.
You know that saying, Joe, right? I thought I was wrong once, but I was mistaken.
You know what? I'm frequently wrong, but never in doubt.
I knew John was right, but I had to get your back.
Thanks, bud. Thanks, bud. Thanks, bud.
Okay.
John, I'm sorry. Go ahead, please.
So
Good job, John.
So, Joe, you know, in European countries, there's one or two countries in particular where they do consume an enormous amount of black licorice, and they do see patients come to the ER with metabolic alkalosis. I'm not so sure we see that too often in our country. But. So you can have a person can overconsume alkaline substances, or just in the hospital, we can overdose somebody with sodium bicarb. So the last one is the most common one, apparently, which is contraction alkalosis or hypovolemia / dehydration. This phenomenon basically occurs when you lose a large volume of sodium-rich but bicarbonate-poor fluid. It causes chloride depletion. And what this does, there's a chloride bicarbonate exchange in the renal collecting duct, and this causes that collecting duct to fail and dysregulate. So you end up retaining far more bicarbonate than you normally would. So this is going to occur so your contraction alkalosis or hypovolemia occurs with vomiting, sweating, diuretics, cystic fibrosis, and I put the note here because people put that up there to scratch their heads. In cystic fibrosis patients, they have a dysfunctional regulators in their sweat ducts, correct? As well as in their GI tract. And this dysregulation causes excessive chloride and sodium losses, okay? Diarrhea, talked about, and then this is not an all-inclusive list. There's many others, but most of them will involve renal dysfunction or some type of aldosterone level, high concentration of aldosterone. The net concentration of bicarbonate increases as a result. Normally, these pathologies are easily offset by the release of hydrogen from the intracellular space to balance the pH in most incidences. But people who continue with metabolic alkalosis have one of these maintenance factors also. And these are the 5 we talked about earlier. So we look at each one of these. So reduced intravascular blood volume. Well, your low blood pressure causes aldosterone released by your kidneys, which is trying to retain volume and increase your blood pressure back up. This increases the sodium and water reabsorption, but it also increases your bicarbonate ion reabsorption. So that's number 1, as well as the excretion of potassium and hydrogen. So this is a double whammy. Whenever you have an increased aldosterone level, you're retaining bicarbonate and you're excreting hydrogen. And that's the price that's paid to try to get your blood pressure back up, but it's driving your alkalosis. In the case of low potassium, intracellular potassium shifts out of the cell in exchange for hydrogen going back inside the cell, which we talked about earlier. This then causes a decrease in concentration of hydrogen, again driving alkalosis. But it also activates the potassium hydrogen HEPase pumps in the renal tubules, which then reabsorb potassium and secrete hydrogen ions in the urine. So that's a double whammy there of low potassium. Hypochloremia, which is generally as a result of loss of vomiting, excessive GI suctioning, and some diuretics, this causes the kidneys to increase its reabsorption of bicarbonate ion, maintaining alkalosis. When you have certain renal dysfunctions, not all, but certain renal dysfunctions, you have a reduced GFR, but in certain renal dysfunctions, you have reduced removal of the bicarbonate ion. So renal insufficiency, whereby the kidney is not excreting the excess bicarbonate ions as it normally would, therefore, again, maintaining your alkalosis. And this one, hyperaldosteronism, which is a very powerful one, usually it's a condition like chronic condition, but doesn't have to be, but Conn syndrome, adrenal tumors, adrenal hyperplasia, or any condition that's going to cause a hyperaldosterone state is going to increase your sodium hydrogen exchange in the kidney, resulting in hydrogen loss, bicarbonate reabsorption, and that's going to definitely drive alkalosis. So how are we going to look at a patient? How are we going to manage the patient? Patient history. First question, are we having any upper or lower GI losses? Vomiting, diarrhea? Is the person taking diuretics? Does the person have any renal disease or renal insufficiency? Did they ingest anything, alkali ingestion? This might be antacids, calcium bicarbonate, which is for osteoporosis usually, excessive milk and excessive black licorice. Then you want to do a physical exam. Vital signs, because again, signs of dehydration, muscle weakness, these are all going to your loss of potassium, your hypovolemia, fatigue, of course, muscle cramps, low potassium. So if you do these things, most of the time you're going to be narrowing in on what the cause is. You can also do some laboratory tests. If you send out a blood test, if the patient is alkalotic, you should see a high sodium, you should see a high bicarbonate, low potassium, and low chloride. If you do a blood gas, you should see a higher pH greater than 7.45. Usually, almost always compensatory. The body's almost always going to compensate for this on the respiratory side with CO2 greater than 45 and usually a bicarbonate level greater than 35. Most commonly by now, the diagnosis will be clear. Vomiting, GI suctioning, excess, low blood pressure, diarrhea, laxatives, enemas, dehydration, electrolyte imbalance, person's poor nutrition, or just hypovolemic. I would say 9 out of 10 people that come into the ER that are alkalotic, they're pretty much going to get diagnosed right there. Cystic fibrosis patients talked about earlier, their sweat glands are dysregulated, their GI is dysregulated. And then the one we see a lot with COPD patients where there's a metabolic compensation and then alkali ingestion. So the treatment for all of these common ones would be basically to immediately correct the volume deficiency. You're going to correct the blood pressure and you're going to correct the electrolyte imbalance. Then you're going to see about addressing the actual cause. If the person is having diarrhea or vomiting, you're going to treat that. If the person's doing something to ingest alkali, you're going to do something about that. So usually you can correct the situation here. But for example, for me in the ICU and for some of us, we see patients sitting in the ICU 3, 4, 5 days, or they were even alkalotic before they came to the OR. Why are they maintaining their alkalosis? It's not a simple case of walking into the ER and being dehydrated. So if at this point the diagnosis is not clear, we need to do a renal panel blood test. Look at their BUN, creatinine, GFR, and look at their sodium, potassium chloride, and calcium. But here's where it starts getting a little more complicated. And this does get complicated, actually. Far out of the wheelhouse of my level of knowledge, for sure, as perfusionist. But we do a urine chloride test. If the chloride is less than 20 milliequivalents per liter, it takes us in one direction. If the urine chloride is greater than 20 milliequivalents per liter, it takes us in another direction. You have to see if the person is hypertensive or not. That's going to play a role. Let's look at their renin activity. If their renin activity level is high, it's going to increase their aldosterone production. Or you can just have high aldosterone without a precursor of renin being elevated. So look, this is where it starts getting more complicated. I'm going to try to keep it simple. But this is the algorithm to look at why is our patient staying in metabolic alkalosis and what can we do about it? Because there are things that should be done about it. So you're going to do your physical exam, your metabolic profile, your arterial blood gas, and if you still can't determine the cause, we need to look at urine chloride levels. Like I said, less than 20 milliequivalents is on one direction, greater than 20 it leads us to another direction. On the less than 20, these should be the main things you would look at. Loss of gastric secretion, diuretics, post-hypercapnia, villainous adenoma, which is going to increase your aldosterone, and congenital chlorodia, which is really a birth defect. It's a congenital chloride wasting diarrhea. These people have diarrhea all the time that depletes their chloride level. If it's greater than 20, now you have to ask the question, are they hypertensive or not with this greater than 20 milliequivalents per liter of chloride? If they're not hypertensive, it takes you down to diagnosis as genetic defects like Bartter and Gittleman's, if they're on certain diuretics, or they could be depleted of potassium or magnesium. If they are hypertensive, you have to look at what's driving the hypertension. First look at, is your renin activity high or low? If your renin activity is high, they can be on diuretics. They could have renal artery stenosis. They could have a renin-secreting tumor. They could have accelerating hypertension. If their renin is low, then you have to look at just their aldosterone levels. Maybe that alone is driving it, and you have a low and high there as well. If it's low, you can look at black licorice intake, something called Cushing's syndrome, taking exogenous steroids, Little syndrome. And then if their aldosterone is high, it's some type of usually chronic condition that's driving a high aldosterone level. So getting back to how we would manage a patient like this. Patient comes in, pH higher than 7.45, CO2 greater than 35, clinical exam, hemodynamic monitoring, renal function, EKG, blood gases. And if the condition is not life-threatening, it's a lot of what I just talked about. But what if the condition is life-threatening? In other words, patient comes into the ER, we don't have all this time to run a urine chloride level and then find out, what else is going on? Is their renin activity too high, or is it their aldosterone? They have a life-threatening condition of metabolic alkalosis. So if it's life-threatening, what does that mean? Well, first of all, a pH should be greater than 7.55, and you can look for the presence of hepatic encephalopathy, cardiac arrhythmia, digitalis cardiotoxicity, or an altered mental status. The mortality associated with, and this is going to repeat what we said earlier, Joe, the mortality associated with severe metabolic alkalosis is substantial, what I said earlier. If you have, mortality rate can be as high as 45% and over 7.65 as high as 80%. So you're going to have these metabolic dysfunctions going on, Joe, with these. So correction by the appropriate intervention should be undertaken with urgency when the arterial blood pH exceeds 7.55 because of these high percentage of mortality. So everybody's always asked, well, if the patient is acidotic, we give a base, we give bicarbonate. If the patient is alkalotic, no one ever thinks, are we going to give the patient some form of acid? Well, you actually can in severe cases. Hydrochloric acid, sodium chloride, which as you know is very acidic, potassium chloride. If sodium chloride and potassium chloride are contraindicated and you need an immediate correction, you can consider HCl. And it just briefly, how would you give the HCl? And it's actually a simple formula, 0.5 times the weight times the desired amount that you want to decrease your bicarbonate level. For example, if you have an 80 kilogram patient, your bicarb is 35, and let's say you want to reduce it 10 points down to 25. So that would be 10 points reduction. It would be 0.5 times 80 kilograms times the 10 point bicarb reduction. You would give a total dose of 400 milliequivalents. The administration rate is 2 milliequivalents per kilogram per hour. So 2 times 80, you'd give it 160 milliequivalents per hour until you gave the 400 milligrams. So that's how you would go about giving somebody HCl in a severe case. You can also give somebody acetazolamide. I'm not going to get too involved with this, but this basically produces diuresis of the bicarbonate ion, which is one of the things that's failing due to the disease process. So condition is not life-threatening. When you read up on all the metabolic alkalosis articles, well, you'll read this and they can put so many different perspectives on it. But one theme that runs through it is when you look at somebody with metabolic alkalosis, they either fall into a chloride responsive category or a chloride unresponsive category. And the chloride responsive category happens to be where the chloride level in your urine is less than 20. Whoops. And this could either be due to excess alkali loading, which you would just discontinue the bicarbonate or any of its precursors that you ingested, or you could have the hydrogen ion loss. Okay, the digestive hydrogen ion loss that we talked about, vomiting, excessive gastric suction. You could also, so in that case, what you would do, you'd give antiemetics, discontinue the GI suctioning. You could give the H2 blockers or proton blockers, ATPase, hydrogen potassium inhibitors. If you have renal hydrogen ion loss, this is usually due to diuretics or low potassium, discontinue those diuretics that are causing the problem. Use spironolactone. That comes up a lot. Spironolactone is a potassium-sparing diuretic. And discontinue any drugs that are increasing or driving the patient's aldosterone. So, in either one of these, what are we going to do at the bottom? You're going to administer sodium chloride and or potassium chloride to correct the potassium, the hypokalemia, and the hypochloremia. And you're going to do volume replacement therapy. If that fails, then you can go to these more severe measures of hydrochloride administration, sometimes dialysis also, or acetazolamide. Now this side of the algorithm gets even far more complicated, but when you really look at it, this is your chloride resistant people, which have a greater than 20 milliequivalents per liter chloride in the urine. And what this is chloride resistant metabolic alkalosis is due to an increased effect of the aldosterone. So treatment of chloride resistant metabolic alkalosis involves correction of the hyperaldosteronism. And there can be so many of those things. So when I showed this earlier, you're looking at the right side there with greater than 20 milliequivalents. You have all these things that can cause high renin activity, which ends up increasing your aldosterone, or direct contributor to increased aldosterone. And you can go through all kinds of diagnosis getting to what the real cause of driving your high aldosterone level is. The problem here is it's not going to respond to the simple administration. So here's the key points in conclusion of everything we've talked about. Metabolic alkalosis is bicarbonate accumulation due to acid loss, due to hydrogen ion loss, alkali administration, or an intracellular shift of hydrogen ion, or renal bicarbonate retention. The most common causes of volume are volume depletion involving loss of gastric acid, potassium, and chloride due to recurrent vomiting, GI suctioning, or diuretics. Those are the most common causes. Metabolic alkalosis involves a loss of chloride, is called chloride responsive. You can treat the cause and give the patients chloride-responsive metabolic alkalosis, 0.9% saline IV, and other electrolytes as needed. But in the chloride-resistant metabolic alkalosis, you need to look at what is the condition or pathology causing and driving the increased aldosterone level. Treatment of this chloride-resistant metabolic alkalosis involves correcting the hyperaldosteronism and using potassium-sparing diuretics like spironolactone. All right, that's all I have. Gives you a headache, huh?
Wow. Yes. Yes. Okay. Dr. Samir, I'm turning this over to you.
I mean, to be honest with you, we see it a lot in the cardiac patients because they're dehydrated, because they're coming in failure, and they diarrhea, and they come till they become alcoholic, and people are scared to hydrate them. But unfortunately, the only thing I can correct anybody's pH by Diamox. Diamox for over 2 days can correct pH with no problem, but that's not really fixing the problem. They are dehydrated. You have to drop some fluid in them. And then we talked about saline before. You have to drop a couple of liters in them. Once you hydrate them, their fine pH is fixed. They will fix themselves. The kidney will respond. They'll fix themselves. You just have to be concerned about their respiratory status. To some of them, it's going to sound weird. You need to intubate them, secure the airway, because they're going to flood their lungs. So, but you have to choose.
Yeah.
And you're not hyperventilating them. You just intubate them, keep the pH normal, which is a little difficult with those patients. But if you do that with Diamox, you'll be good.
I mean, doesn't really, I'm assuming it really matters whether or not it's a chronic
It does matter. Yeah.
alkalosis versus an acute
Right.
situation.
And John is correct. I mean, you can do the studies, the chloride studies, but the problem is those chloride studies, they get very altered by the diuretics. And so you run into, becomes like really a very mass picture. So I have to get somebody much smarter than me, endocrine/renal, involved in these stories. But to be honest with you, Diamox is a great drug, and I'm used to it because it's a very cheap drug, and you can use it a PO or IV, whichever way form you want, will correct the pH. But you really not treating the problem. Hydration. That's it.
Right, when you get back to the bottom line, it's so much to do with hydration. But see, that's what's interesting, Joe. You have almost probably 90% of our ECMO patients on CRT. We're constantly trying to dry them out, right? To dry their lungs. And we see metabolic alkalosis in the unit, right? Sometimes because of that. Not always, but occasionally we see.
Well, your CRT solution can be driving that because
Absolutely.
you have two
The
choices
base.
of fluids. You have the 32 bicarb, which is much higher than what 24 being more normal, right? So you're adding, and then you have the lower bicarb solution, which is I think 24, 26.
24.
So it really depends on which solution you're using, which is going to have an effect on that. Yeah. You feel the same way. It's
Yeah.
really your fluid selection
Absolutely.
that you're using, and you can
I-
dilute your CVVH fluid, your CRRT solution. You can have a bag of that on one scale and a bag of normal saline on the other, and this will counter your sodium load from the saline, but the saline will dilute out the bicarb from the CRRT solution if you don't have the low bicarb solution. So you can mix and match if you really understand how the CRRT machine works.
And to be honest with you, a good renal guy can balance it and make. So you really have to depend on them a lot.
But based on my error, which I'm again, it wasn't really an error; it was a test, and I want to make sure you understand that.
You
But when
understand it's a test.
but whichever way you shift it, alkalosis increases the affinity of the oxygen for the hemoglobin, meaning it's not going to release it to the tissue. So perhaps, and I'm assuming this, because I've really never thought much about it. I've seen alkalosis before, and really didn't think much of it, because usually you go on pump and it sort of corrects itself because we're creating a environment, maybe a little hypoperfusion, who knows what. But I've seen it just sort of correct itself. I've really never dealt with somebody who had this chronic alkalotic issue, but or persistent, let's say that way, rather than chronic, persistent. But if it does decrease or increase the affinity for oxygen to hemoglobin, which means it decreases its release to the tissue, do you get a relative tissue hypoxemia associated with that. Can that happen? Dr. Samir?
Yeah.
Yeah, I think that's the concern. I think
Is
that's
that
what I
what
learned. That's what I
to be
learned
honest
from
with
this.
you,
yeah.
I mean, you really can correct that easily. To be honest,
It's easy to fix.
Yeah.
Just give some saline. So here we're talking about using saline to correct alkalosis, but yet how many people, I don't mean to change the subject, advocate the use of pouring saline in for resuscitative measures? So does that make sense then? So you have a patient who you're resuscitating and they're not alkalotic, you're resuscitating them, their fluid volume, and you give them something that you would use to correct alkalosis. It seems to me that's somewhat counterintuitive. You're causing quite a bit of acidosis.
I don't think you like saline that much, but I love saline. I like use
You do?
I love saline.
I hate saline.
You know why? Because too much LR is not good for you either.
Yeah.
Well, a lot of
See my
it.
buddy here?
Agreed.
Yeah.
We're gonna be against you now. I'm sorry. I'm not against the leader now.
You're going to be against me?
Yes, because forget the leader situation. Too much. I don't like the LR. Too much LR is uncontrolled.
Well, I don't like ractated lingers either, but I mean,
Because I'll tell you, John, one
yeah.
thing I don't like for sure is giving HCl.
Yeah.
Yeah, yeah.
HCl is not. There's no good thing about giving HCl.
That sounds a little dangerous.
I hear.
Yeah, it
A
is.
little
And,
risky.
and now you can, if you give it fast enough, you can go demyelination and all kind of brain issues, and it's just like the opposite of the other situation.
Yes.
And you don't want that.
Yes.
I
Yeah,
don't-
that's right. A rapid, well, that's like sodium too. You get that demyelination from a
Exactly.
rapid correction of
And
hyponatremia.
you know, I don't have much brain left to demyelinate that quickly.
I understand.
So-
I
so-
understand.
so-
Okay, fair enough.
Yeah, so HCl, really, I'm not a big fan of HCl.
Mm-hmm.
And it actually gives bad phlebitis. I mean, you have to have a central line. It's like a whole other drama.
Right.
you
Yeah.
know,
Yeah.
so-
You're better off just. I
Yeah.
mean, just put them a Herker catheter in, and just put them on CRRT, and just use them. You know, if you
But-
really wanted to. If
but
you
you
didn't
know
want to
something,
just
Jim?
give. If you had a fluid management issue, so you didn't want to give saline diluted or something else to correct it, you could just give just put them on CRRT.
But Joe, you have to remember, I cover hospitals that they have to call a special person to come in at night to do CRT. So the easiest thing for me is to drop.
How does that
into-
make sense? Are you kidding me? How
No,
does
I-
that make sense?
Sir, the world is very.
The nurse at the bedside should be able to
not
set
every
that up so quickly.
not every nurse.
I've been to a place where they
Yes.
don't even.
Thank you, John.
They're so painful for them to call in somebody from the outside to do that they set up a hemoconcentrator and they do poor man's CRT.
pitiful.
Yep.
I,
all the
I-
time.
I'll tell you what I do.
We're
is-
spoiled.
Yes.
Well, no, we encounter that at a couple of hospitals too. I'm not going to say any names, but
First,
yeah,
first of all, it takes the company
at CRT.
day or two to respond.
Yeah.
They come. The equipment is expensive. The people, I don't know. It's
You have to get a renal consult for them to come
Yep.
in. And I'll tell you, so for me, I would see the patient respiratory status. I either intubate them prophylactically, a couple of liters of ANS, and give Diamox around the clock, and then like a full 2-day doses. Then I'm good, safe. In 2 days, I'm good. Like
Yeah.
I know that's gonna be okay.
Well, I'm going to go out on a limb here and be
You're on your
something
own
that
now,
I'm
for
not
sure.
I'm not normally provocative, but I'm going to be provocative.
Really?
Right now.
you're not
Yeah.
normally.
I'm not going to be. I normally am not provocative. Can we close that door so we keep the heat in out? Yeah, thanks. Thank you. Why is it necessary to have a renal consult to order and utilize CVVH, which is a form, I understand, of CRRT, for patients? Why? Is it just because the word renal is in CRRT? Because to me, I love nephrologists. I get along very well with most nephrologists. I think some nephrologists are great. But I don't believe you need a nephrologist to order and run a patient on CRRT if it's not being used for primary acute kidney injury or acute renal failure.
I will answer that for you. That in any cardiac surgery OR, that sounds very logical. But for you to do a liver transplant and need CRT, you need to have a renal person covering that. Because the problem is, there's nobody like me or like you that's gonna handling that situation. So you will understand the pump, you understand electrolytes. They need somebody responsible to be handling that situation for the hospital itself.
That
And
should be the intensivist.
the hospital will gonna want a renal person that's gonna handle that and part of their privilege coverage. The intensivist does not have CRT privileges. They can put a line in and they will manage, but it's all about privileges. And I know it sounds a little weird, but you have to have privileges for it.
It's counterintuitive
I understand. But,
because that's what we do all day in the operating room.
Yeah, an intensivist who can ask to initiate CRT. And for you, the operating room, there's no hesitation because you're
In the ICU, we do it all the time. Our department teaches the nurses, and now the nurses, they just do it, they teach themselves now. But in the early days, we taught them how to do CRRT. That what do you do when you're handling a patient in the ICU? You're administering fluids, you're maintaining you're making the decision whether the patient needs a run of potassium or not. You're deciding whether they need some bicarb or not. You're deciding whether or not they need a fluid challenge. You're deciding whether they need a diuretic. So again, I'm not trying to stir the pot here, but why do you need a nephrology
Because
consult
some hospitals
just
wanna
to hook
cur-
somebody up to a fluid management system, which is what it is, simply because it has this term CRRT, continuous renal replacement therapy.
pretty much-
That's what's killed the whole practice. of it.
curb the usage and by making sure that the renal person thinks that it's needed. There's resources mobilization and there is also budget issues, you know that. So getting those resources, getting a renal person in the middle of the night, so whatever John and I are talking about, it's not easy and it's expensive.
Exactly,
So-
but that's to the detriment of the patient and to the detriment of getting the patient out of the hospital faster, which would be ordinarily then a less expensive model for the hospital. So why do we continue to allow for a system that's dysfunctional to pervade? Not that I want to be provocative, it's just a question.
Okay, can I ask you one question since I'm going to get more controversial? I can do that. How many hospitals do you work in that can get a stat echo in the middle of the night? Echo done and read.
Oh, echo done in red?
And now I have here my buddies now ganging up now.
All right. Row,
What's
how
that?
many?
Ooh, not a lot.
And
Not a lot. You have to call that specialist.
that I think an echo for our business is a standard.
Oh, it is standard.
Yeah.
Yeah, especially in Impella.
Yeah.
Like, your Impella's out and you've got to call that echo, and it's, almost an act of God. It has to be done, but, that could be 2-3 hours.
See, and that's what I remember, and Vicky remembers this. I was in Mexico. We were down in Querétaro, Mexico. Heart surgeon down there, Dr. Angel Gamboa. And what a great guy, super guy. And we had this patient, we were doing some work down there. I won't describe the work, but we were down there. And we had a patient we needed to get an echo on. And he left the room and he came back pushing this cart with the echo on it, and he started turning everything on. And I said, you know how to run this thing? And he said to me in Spanish, Joe, I am a cardiac surgeon. I can do everything. There you go.
There it is.
So,
There it
Dr.
is.
Gamboa, shout out to you out there if you're watching. I think your wife is watching. I saw his wife was on. So it's good to see all of you. Anyway, Metacruz. Yeah, hey. Okay, good discussion, good talk. Not sure where it got us, but good talk.
I think take-home message is when you get alkalotic, we can become hypoxic.
You have a phone call?
And I don't think that most perfusionists have ever actually considered that you get hypoxic as you get further and further more alkalotic. That's not necessarily the case with acidosis, right?
You need to fix. You really need to fix that. The fix is easy if you fix it early.
It's early.
You have to
wait-
fix it. Yeah, you have to fix it. Yeah, and don't hesitate fixing it. So you're gonna give a patient additional volume. It's okay. You know what I'm saying? So-
Right. Yeah, it seems to be linked to the original slide I was low
Yeah.
volume, low potassium, and low chloride, which are almost always fixed
Exactly.
in hand in hand anyway when you give the.
Here's a question from Facebook. How do you handle dysauxia issues?
In which context?
I'm assuming in this issue of what we're
Well,
talking about.
well, that's what I was just saying. The reason why
Yeah.
I did this talk and the reason why it became important, we talk about acidosis all the time, we treat it, but that's not causing hypoxia. Alkalosis causes hypoxia.
Right.
And we should care about that. And at some point,
Tissue hypoxia.
Right.
Tissue
right.
hypoxia.
So you might
everything looks good.
Right.
in the
Everything's
blood
going to look
gas.
great. Your SVO2 is probably going to look wonderful because you're not releasing the hemoglobin as well.
But then won't you eventually then develop more hydrogen ions and become
Well,
more?
if you have tissue hypoxia, you can have high lactidemia. Then you go to So I think I
Yeah.
tell you, if you do not hesitate. If you're in the OR, just give Valium.
Yeah.
If you're outside the OR, secure the airway and give Valium if you're concerned about respiratory status. A lot of people are worried, they're going to flood their lungs. It's okay to flood your lung. We can intubate you. Don't hesitate.
Treat it.
Yeah, treat it.
So you don't end up with
Exactly.
with some end organ system which ends up with a relative hypoxemia that causes a dysfunction later.
And don't hesitate to start Avidamox. Avidamox does work. It's very, very cheap and it does work.
Okay. Fair enough.
Okay.
Okay, very good. Excellent. That was just, I wasn't sure how this was going to go, but it went really well.
Well, let me ask you
I
this.
think it's an ignored topic, so I appreciate you, John, a lot.
Real quick, let me ask you this. So if you have, let's say we're on perfusion, and you have good oxygenation, and your SVO2s are great, let's say better than normal, which if you're running an alkalosis. I see this the other day. Base excess was 8 to 10 the whole time on pump. And I walked to the perfusion and said, why is the person alkalotic? I don't know. That's just the way it is, that's how he came in. Well, now we find out the person could be hypoxic. How do you know they're hypoxic? How would you know that? If you don't run
Lactate levels
lactates,
going up.
yeah, but a lot of people don't. A lot of people do, but a lot of people don't run lactates.
you should.
should because the
if you have a
the
concern.
iStat cartridge has one.
Yeah.
But if you have,
Or you could just wait until your
if you have
pH
good-
starts to normalize because of the relative acidemia secondary to the hypoperfusion.
sometimes it persists. So if you have persistent, so if you have good oxygenation and a better than normal SVO2, and your lactates are rising, you're not releasing the oxygen because of your alkalosis.
That's true.
In the setting of a metabolic alkalosis.
That's true.
Absolutely.
But
So
I
that's
think-
something we could take home as perfusionists.
But I also think
I think
that
lactate should be measured really.
Yeah.
If I want to say routinely, a lot of people attack.
Yeah.
Lactates are really a good measure of what's happening, and it will tell you if you're doing the right thing or not. It's a simple number that will tell you if you're
Tells
doing
you a lot.
Yeah, if you're going the right way or not. Right now the government mandates if you come to the ER and your lactate is high to be treated aggressively for sepsis. And I'm not saying about septic, but it tells you about tissue hypoxia.
Right.
absolutely.
So if your lactate is high, there's a problem. And the government did not go that far, except because the lactate, measuring lactate trends are very important.
I think
it's all
so.
about the trend. It's not just
And
absolute number.
It's so unappreciated. And how many times do I'm on the phone with you guys about something, you guys are doing an ECMO, what's the first thing I always ask? I ask it all, what's the lactate?
What's the lactate?
Has anybody run a lactate? And so many times nobody has yet.
Right.
And it's just amazing to me because it is very, very important. Because next, I think in October, one of my talks is going to be on incident dark field imaging and looking at the microcirculation in the sublingual area, which is a great opportunity to see it, and I'll talk more about that. But with these septic patients, but also septic-like syndromes that you see from inflammatory responses, you have this hyperdynamic macrovascular system, but the microvascular perfusion is horrible. And you see this, like he said, lactated. You have to treat that urgently,
Absolutely.
or you end up with a patient who just isn't going to make it.
Let me tell you, I had the fortunate luck to be a physician in one of the marathons, and we had we signed the runners before the marathon. We got a release that we can measure lactates on the Medand. And you'd be amazed at those high lactates. These are healthy guys.
Yeah.
Healthy as can be. You're amazed at this high lactates.
Really?
Some of them had to transfer to the hospital and
Yeah.
hydrate.
Yeah, because
Based
they'll
on
go
the-
into ARDS.
Exactly. And I'll tell you, you would be amazed at those high lactates, how high they can get. These are healthy people. Okay?
Yeah, you taught me that.
So I'll tell you, I think lactate's an important measure. And you just mentioned that trend. It's a cheap test.
Yes, absolutely.